All right, let's dive right in. Today, we're talking about the high-stakes world of infectious diseases. This is a field where every single decision counts, and where common, easy-to-fall-into traps can have some really serious consequences. This isn't about memorizing a bunch of facts. It's about having a solid game plan.
It really all boils down to this one question. When you're in the heat of the moment, you've got a patient right there in front of you. Having the right strategy is literally the difference between a good recovery and a total disaster. So how do you make sure you make the right call every single time?
Well, the answer is to stop thinking like a textbook and start thinking like a strategist. And that's exactly where the Mastery Playbook comes in. Think of it as a set of high-yield strategies, plays, designed to help you navigate the absolute most complex and critical clinical scenarios out there.
Okay, here's our game plan. We're going to break down 4 essential plays from the playbook. We'll start with decoding fevers, then talk about knowing when you have to treat first, no matter what. After that, we'll tackle the great masqueraders, and finally, how to eradicate hidden reservoirs. Then, we'll wrap it all up with the core principles you can take with you to the ward tomorrow.
First up, play number 1, decode the fever. So, picture this. A patient shows up with a high fever. Is it a virus that's causing their blood vessels to get all leaky? Or is it a bacteria that's actually invading their gut? The management for these two is completely different, and trust me, getting it wrong is dangerous.
Now, this is where it gets really interesting. On one side, you have dengue. What's crazy here is that a second infection is often way worse because of something called Antibody-Dependent Enhancement, or ADE. Basically, antibodies from the first infection actually help the new virus get into cells, kicking off this huge inflammatory response, a cytokine storm, that makes plasma leak from blood vessels. Now, on the other side, you've got typhoid. Totally different story. Here, salmonella bacteria are invading the gut, getting into the bloodstream, and causing that classic stepladder fever. One needs careful fluid balance, the other needs specific antibiotic.
And this brings us to an absolutely critical point for dengue. This is a never event. The single biggest mistake you can make is causing fluid overload. Yes, you need to hydrate them, but pushing too many IV fluids can lead to life-threatening pulmonary edema. It is a very delicate balancing act, and remember, paracetamol only for the fever, absolutely no NSAIDs, because they just increase the risk of bleeding.
Okay, now for typhoid, let's talk diagnostics. If you are still ordering a Widal test, you need to stop. The CDC is crystal clear, it is obsolete. It's just notoriously unreliable. The gold standard, the test you should be using, is a blood culture. It's about 80% sensitive in the first week, and the rule is simple. Send the culture before you start antibiotics.
So, which antibiotic do you reach for? Well, this number is your guide. In many parts of Asia, quinolone resistance is over 80%. Just let that sink in. That means if you start a patient on ciprofloxacin, there's an 8 in 10 chance it will fail. That's why the playbook says you have to address resistance head-on and default to stronger options, like ceftriaxone or azithromycin from the get-go.
All right, let's move on to play number 2. This is what we call the treat first imperative. Sometimes waiting for a lab confirmation is a luxury you just don't have. There are times when one single clue should be enough to trigger immediate action.
And this right here is a perfect illustration. This is scrub typhus. It starts with a tiny chigger bite and can progress to systemic vasculitis and even multi-organ failure. The key clue, the thing you cannot miss, is the Eschar. Waiting for an IgM test to come back is a fatal delay, because every single day you wait, the mortality rate, which can already be over 10%, just climbs higher and higher.
So what is an Eschar? It's this black, scab-like lesion that you'll find at the site of the bite. If you see this on a patient with a fever and you're in an endemic area, that is your command. You don't wait. You start doxycycling immediately. The risk of doing nothing far, far outweighs the risk of treatment.
Next up, play number 3, master the masqueraders. Okay, this is where it gets tricky. Some diseases are notorious for mimicking other conditions. To unmask them, we have to ditch our old habits and fully embrace the precision of modern diagnostic tools.
So let's look at 2 of the greatest masqueraders of all time, tuberculosis and syphilis. For TB, forget the Mantoux test. It's plagued by false positives. The gold standard today is GeneXpert, which is not only highly sensitive, but also detects resistance. For syphilis, you need a 2-step serology approach. First, a screening test like the RPR. If that's positive, you confirm it with a highly specific test like the TPPA, which looks for antibodies directly against the syphilis bacteria. Using both is key. See? Modern tools give you definitive answers.
And modern tools are now matched by modern treatments. Just look at the progress in TB therapy. We've gone from these grueling regimens lasting over a year to a standard 6-month course for drug-sensitive TB. And even for multi-drug-resistant TB, we now have shorter, highly effective regimens based on drugs like bedaquiline. It's a real game changer.
But with a master masquerader comes a master mistake you must avoid. Never ever start a patient on steroids for some other inflammatory condition without definitively ruling out active TB. Why? Because steroids suppress the immune system, and they can cause latent TB to just explode into a disseminated, life-threatening infection. It is a catastrophic error.
Now for our final play, number 4, eradicate the reservoir. See, it's not enough to just treat the acute symptoms. Some infections, they're sneaky. They leave behind dormant forms, a reservoir, that will cause a relapse if you don't treat the entire life cycle.
This slide shows 2 classic examples. With Vivax malaria, chloroquine kills the parasites in the red blood cells, but it doesn't touch the dormant hypnosolites that are just sleeping in the liver. Same thing with amoebiasis. Metronidazole kills the invasive trophozoites causing the colitis, but it leaves the cysts in the gut completely untouched. And what does that mean? It practically guarantees that patient will be right back in your clinic in a few weeks with a relapse. To kill those Vivax hypnozoites, you need primaquine. But this comes with another critical never event. You must screen for G6PD deficiency first. Giving primaquine to a G6PD deficient patient can trigger a massive, life-threatening destruction of their red blood cells. The rule is absolute. Screen first, always.
So, we've walked through the plays. Now let's distill all of this down into the core principles of the Mastery Playbook. These are the key takeaways that should be guiding your decisions every single day.
First, trust modern diagnostics over old habits, because GeneXpert for TB and blood cultures for typhoid give you certainty, while old tests like Mantoux and Widal can lead you completely astray. Second, treat empirically when a delay is deadly. If you see that classic Eschar in a patient with a fever, that is your signal to start doxycycling right away. And third, this is so crucial, know the never events by heart. No steroids in potential TB, and absolutely no NSAIDs in dengue.
And let's keep going. Fourth, practice aggressive antibiotic stewardship. Always choose the right drug for the right bug, just like we saw with typhoid resistance. Fifth, always eradicate the full life cycle to prevent a relapse. Remember those dormant forms in Vivax malaria and amoebiasis. And finally, sixth, respect the clock. We saw how a delay in treating scrub typhus can be fatal. That sense of urgency is a core principle.
We've covered a lot of ground, from decoding fevers to mastering the great masqueraders. The real question, though, is how will this change what you do? So I'll just leave you with this one thought. Which of these plays will you put into action tomorrow?